Please welcome Jeff Greene.
Thank you, Dick. The healthcare, and healthcare cost crises, plural, poses one of the greatest risks to our nation. And when my friend Don Swift asked me if I'd be willing to speak at this event, I think he knew the answer to that question. Anytime, any place, I'm prepared to talk about this topic. So let me put this crises into perspective. This graph illustrates life expectancy and cost amongst developed nations around the world. And the linear regression that passes through these points implies that nations that spend more money on their health care have citizens that live longer, which is all well and good until you superimpose the United States. And once you catch your breath, you realize that we have a shorter life expectancy, and yet we spend twice as much on average as other developed countries, which simply says that we're not getting our money's worth from our healthcare delivery system. Crisis number 2 has to do with our health status. Here's obesity rates amongst developed countries around the world. And as you can see, the United States sticks out like a sore thumb. 35% today of our citizens are clinically obese, not overweight, clinically obese. The military reports they struggle finding enough fit men and women to defend our country, which says we've got to do something about improving our health. And then the third crisis has to do with cost. The trend lines at the bottom represent overall inflation in wages, and then the escalating line graphs represent healthcare inflation and the amount of money that's withheld from a person's wage to cover their health care. And every year these lines diverge, and every year we say something has to be done about this, which has now created disruption in the marketplace, as this collage implies, such as our largest drug chain, CVS, purchased our third largest insurer, Aetna, which indicates that we're going to get our primary care from our local drugstore because costs are so out of control. Walmart and Humana are in discussions to mirror this. And then corporate giants Amazon, Berkshire Hathaway, JP Morgan Chase, not involved in healthcare, have formed a healthcare company because, like Warren Buffett says, costs are acting like a hungry tapeworm on the American economy. So whether the solution is in the private sector, which these corporations hope it will be, or if it's in the public sector, most experts agree that this one issue will decide our next president. So what if someone came along with a simple idea that solved all three of these problems? Let me tell you a story. Once upon a time, researchers at Harvard and Stanford came together, and they created a web-based incentive system that they thought would work. They tested it over a number of years, and sure enough, it has worked. So I'm going to tell you how it works, why it works, and how well it works. The first thing that these researchers discovered is that health literacy, an overlooked, undervalued remedy, is the single strongest determinant of a person's health status, life expectancy, and cost. Study after study has confirmed this fact. In fact, the World Health Organization says it's a stronger predictor of a person's health status than employment, education, income, race, or ethnic group. CDC says inadequate health literacy is associated with higher rates of emergency room use, hospitalizations, and mortality rate. And I'm going to bring your attention to the first two, hospitalizations and ER visits, because these researchers at Harvard and Stanford use these metrics as a means to determine the effectiveness of their program. With regards to cost, the association of health literacy was demonstrated in this study conducted at the VA, where researchers found that veterans with inadequate health literacy consumed nearly twice as much health care as did veterans with adequate health literacy. ×2, that's a huge factor. So they concluded if we could elevate health literacy in the population, we ought to lower emergency room visits, hospitalizations, and cost. Not only is health illiteracy harmful and expensive, it's also prevalent. Only 1 in 9 Americans have what's called proficient health literacy. So they studied and concluded that when people know how and why they become empowered, empowerment leads to motivation, motivation leads to compliance, and they coined a term. It's called the knowledge, empowerment, motivation, adherence, or KEMA response. And they concluded if they could deliver the right information at the right time and the right way so a patient can make an informed decision, they could affect the KEMA response. And then they learned that this actually had a term. It's called information therapy. And then they studied incentives that are designed to improve performance of doctors and improve the health behaviors of patients. And they likened this to a three-legged stool. They conceived that if they could align the incentives between these key stakeholders, the doctor, the patient, and the insurer, that they could improve health and lower cost. And yet what we've been trying for decades now is really two methods, one in which the insurer incents the plan member, like wellness and prevention, high deductible, consumer-driven health plans and the like, always produced inadequate outcomes because the doctor was left out of the equation. And conversely, when we tested incenting the provider like HMOs and other pay-for-performance models, and the patient was left out of the equation, it again produced inferior outcomes. And yet we've tried this over and over and over again. Then they learned of some researchers at the University of Pennsylvania that had been studying incentives in healthcare, and they concluded, these UPenn researchers, that if you align the incentives between the patient and the doctor, you can produce superior outcomes. And they conducted a series of studies, one of which is shown here. And sure enough, when you align incentives between doctors and patients, you can produce a better outcome. So back to their three-legged stool, they concluded that if we could create a web-based intervention and sit in between these three stakeholders and say to the doctor and the patient, we will reward you financially if you incorporate information therapy to elevate health literacy in an aligned method that we're going to call mutual accountability, then we'll send a signal to the insurer and both of you will be rewarded. And the benefit to the insurer is that costs should go down to the point that you'll realize a return on investment. So that was their idea. They called it the Mutual Accountability Information Therapy, or MATE program. They filed for and received 4 patents, 3 US patents and a Canadian patent. So how it works is that it's a voluntary program for both doctors and patients. It occurs with every office visit. The doctor is offered a financial incentive when he or she receives an email or a fax that directs them to the website. They enter the patient's diagnoses. Up pops a list of 5th grade level educational content relevant to that patient's diagnoses, and the doctor simply selects one for which they get paid 20% more for that office visit. Fast, easy, lucrative, but extraordinarily impactful. The patient's experience begins at home. After the office visit, they receive an email or fax that tells them that they can earn a financial reward for doing 5 simple things. First, read the prescribed article. Second, take a test, open book, but we need you to demonstrate and document that you understand how to self-manage your health. And what these researchers realized is that this was the first time in medical history that anyone was routinely determining whether the patient was competent in self-managing their health. Another first in medical history was the next step. These researchers asked patients to declare whether they're going to be compliant with what they just learned, or if they're not, why not? Provide a reason, such as, I can't afford it, makes me feel bad, I don't think it's effective, I think my doctor got my diagnoses wrong, I'm being overtreated, undertreated, or I just don't want to do it. And then the fourth step was the patient must agree to allow their doctor to see their responses. And this invokes something called the Hawthorne effect, which teaches that we're in our best behavior in the presence of an authority figure, especially if that authority figure is someone that we trust and respect, like our physician. And then the final step was turning the tables and asking the patient to rate the doctor's performance based upon what they just learned. Fast, easy, simple, but effective. So how effective? The Harvard-Stanford group conducted 2 studies, both of them in the state of Texas. The first study involved a health plan, a fairly large health plan, where a subset received the program as a benefit, compared to the non-covered population over a 3-year period of time. And what they discovered right off the bat was how well it was received. Very, very high levels of participation by both doctors and patients, and in turn, thousands of voluntary testimonials posted on their website explaining how much the program meant to both the doctor and to the patient. And then they moved on to measuring hospitalizations, ER visits, and cost, and this is what they found. With regards to ER visits, the covered population outperformed the non-covered population in trend by 6.1%. And in terms of hospitalizations, the more expensive of the outcomes, it was a 20.3% better outcome for the covered population compared to the non-covered population. And then in terms of cost, the non-covered population is on the left, the covered population is on the right. They analyzed the baseline, projected it over the term of the trial, and then measured the projection against the actual, both for the non-covered population and the covered population. This translated to $37 million in savings over a 3-year period of time, compared to the $4.4 million spent on the program, equates to an 8.4 to 1 ROI. Eureka. They solved it. Better health care, lower cost. Then they went on to another study, a smaller group, about 1,800, 2,000 people, where they took a deeper dive. It was a pre-post examination, 2 years before the program was implemented, 3 years after, and then they compared again hospitalizations, ER visits, and cost, and they were astounded. Hospitalizations are on the left, ER visits are on the right. Hospitalizations dropped 32% after the introduction of the program. ER visits dropped 14%, and cost dropped 10.8%, producing $3.7, almost $3.8 million in savings, compared to the $500,000 that the health plan invested in the program. Works out to 7.5 to 1 return on investment. So it worked. So what's the moral to this story? Well, before I get to the moral of the story, I have to be honest with you. Everything I told you is the truth, except for 2 things. Number 1, the studies weren't done in Texas. They were done right here in Oklahoma. And number 2, it wasn't some researchers at Harvard and Stanford that came up with this invention. It was my colleagues and yours truly. So the moral to this story is this: good ideas to solve huge problems can originate in unlikely places like Oklahoma. And finally, if we want to save our country from economic ruin, it is simply a matter of aligning the incentives and making sure that we promote health literacy. So if there's anything that I've said that inspires any of you, I'd love to hear from you, but I have to be honest. Hurry, because our country is running out of time. Thank you.